Want to say thank you all for joining us today. We've enjoyed these monthly conversations about various issues related to public health directly, talking about a public health department or some various, sort of tangential issues. One of the things that we're trying to do, I should introduce myself. I'm Kevin Ressler, President and CEO of United Way. So welcome. One of the things that we're really trying to do here is help broaden the conversation around public health. Too often people hear public health and they think public health care, or they think real narrow banded, the affordability of healthcare. And those are all components, but if you begin to enter into this world, you realize that we're really talking about community wellness, and that sense of community wellness is a much broader picture than just healthcare. That does not mean that these conversations are not often driven by healthcare professionals, nor does it mean they shouldn't be, but it's important to understand things, and I often like to point out that wearing a seatbelt was a public health initiative, right? So we don't think about a seatbelt as part of healthcare, but that was a public health initiative. The water cleanliness in America, which is unfortunately on decline, has been a public health initiative. If you go to not just the developing world, but also the developed world, Europe and those places, they don't have the same ability to drink broadly out of the tap as we do in America, because in America, we have had a historical appreciation for public health, even when we haven't called it that, sometimes even more so than we call it that. And so as we've navigated these various conversations, one of the things that's important to recognize is that those of us who do work within the sphere of progress, I want to say, don't always do it perfectly, right? Because we're willing to take risks and challenges, and because we're willing to re-envision the way the world works. And so one of the things I've been grateful in these conversations is the ways in which we've received various levels of feedback and other things as people are saying, hey, I know something about that. And I didn't think that spoke exactly to how my understanding was. One of those pieces of feedback, our last conversation was about vaccine equity. Our presentation was presented around the data statistics that have been tracked for hard to reach populations, for those communities that we have not been able to get the vaccination for. And one person reached out and said, reached out to me and said, hey, there was no representation on LGBTQ communities. And that's a community that, has in some cases have challenges because some of these vaccine sites have been in churches, and some of those churches have been historically hostile to those communities. And I think that voice should be in that space. Now, that was not the conversation we were having. It was about racial equity. The presentation was around that, the panelists, that was their expertise. But not just because it's Pride Month, but also just because absolutely, let's make sure that that's a part of this conversation. So we have invited for this conversation, Karen Foley, who is the director of the LGBTQ Coalition. And we have Beth Riley, who is part of that community, who will be able to speak some from her personal anecdote, but also has spent time in Fortune 500 companies at the upper echelons of business, and knowing from a finance perspective and thinking about what businesses have to think about when we talk about issues of health and public health and communities of identity and those things. We also have two individuals who I believe are both returners, Dr. Sri Livingston, who is a United Way board member, I'll mention as well. She is the director of obstetrics, or is it both obstetrics and gynecology?
It is. OBGYN, yes.
So OBGYN over at UPMC Lidditz. And so she, in partnership with Dr. Cherise Hamlin down in my lower left, have worked with the beginning of an organization that is rapidly growing in influence and impact, Patients Are Waiting, which was founded by Dr. Hamlin, who is also a OBGYN, but for the Penn Medicine system. And so grateful for her coming back and talking about race, identity, and some of those issues that will show up inside of the medical facilities and systems. We also have Sandra Valdez, Sandra is the Chief Operating Officer for SACA, which is Spanish American Civic Association, for those of you who don't know it. That is an organization that focuses on providing resources and supports and advocacy and a whole bunch of things. They've got a TV studio, they've got a radio show, and their focus is on the Latinx community and that diaspora, but also others who live within those communities with them. And so their headquarters is 2 blocks from my house. They do amazing work. Have done housing and healthcare, and that organization existed in a time in which was even more difficult for access for certain members of the community. And so bringing in that part of nonprofit sector, the Latinx community and some of those things. Then our moderator for the panel discussion will be Susan Baldridge, who's was a longtime investigative journalist for LNP, Lancaster newspapers, as well as has been for the last number of years serving as the executive director for the Partnership for Public Health, which, for full disclosure, I am on the board of. And so want to make sure that we're bringing in a wide and broad level of conversation here, and that we do this in a way that helps, like, yeah, go away. I love you, but I'm busy. So that is done in a way in which this conversation is able to be one in which we breathe in learning and we breathe in ourselves and we learn from one another. That's the goal of our conversation series here at United Way. I would be remiss in my job if I didn't say we always appreciate financial contributions to the United Way to help us do this work and the other work that we do, including funding other agencies. Thank you so much for your support. Without further ado, I'm going to introduce one last person who I'm really excited to work with again. Recently, we worked together on a panel for Millersville's conference around sustainable development goals, and she gave a wonderful presentation. Her name is Rebecca O'Shea. She works with the United Way of Pennsylvania and their advocacy wing, and she's going to talk to us about a little population we like to call ALICE. ALICE is the population that we define in our United Way world and broader as assets limited, income constrained, employed. Sometimes you'll hear this used as working poor. That's not a great term from a dignity perspective. And so we want to honor the realities of the individuals. And so we use the acronym ALICE. Rebecca is going to talk to you about the ALICE population, share presentation, and then that's going to help us kick off our conversation today. Again, thank you so much for being here. There's the Q&A section. It is being recorded. If you registered, you'll get a copy of the recording. There's a Q&A section here to ask questions, and we'll work those in as best as we can within the time allotted. Because we only have a certain amount of time allotted, I am now going to stop talking, mute myself, and figure out what my daughter needs. Thank you so much, everybody. Welcome to the conversation. Thank you, Rebecca.
Yes, thank you, Kevin. I'm going to go ahead and share my screen for everyone to take a look at my presentation. Maybe, there we go. All right. Hi, everyone. So like Kevin said, my name is Rebecca O'Shea. I am the advocacy coordinator at United Way of Pennsylvania. In my job, I work a lot with policymakers, legislators, and advocates to develop smart policy solutions to a lot of the issues that our communities face. And one of the communities, as Kevin mentioned, is ALICE. And as Kevin said, ALICE stands for Asset Limited, Income Constrained, Employed. And the way I like to define ALICE is that it's the population that's living above that federal poverty level, but below financial stability. So as Kevin said, they are commonly referred to as the working poor. I don't like that term. Most United Ways don't like that term. It takes a lot of dignity away from these people because this community truly is the backbone of our economy, and they are our neighbors, they are our friends, they are our family members, and they deserve to be recognized for all that they contribute to our communities for. So one thing that we do when we define ALICE is we define it through budgets. And the first budget I have is the survival budget. It's a good measure of the cost of essential items to basically survive. It's not the end goal. It's by no means something that you want to strive to. And I will show you the numbers to kind of give you an idea of how low this and conservative this number is. So that's just one look at it. The second budget we also have is the stability budget, which is a little bit better measure of what it costs to be able to be financially stable and sustain a household in this economy. So I will show both of those numbers as well. And then one thing that United Ways do is we want to engage in businesses, we want to engage with government, and we want to engage with our partners to advocate for this community. And again, to advocate for those smart policy solutions to help ALICE move along to a path of financial stability. So when we say who exactly is ALICE, the numbers are kind of shocking. So it's nearly 1.4 million hardworking Pennsylvania households, or 27%. And then when you couple that with households that live below the poverty level, you're looking at about 2 in 5 households that are struggling to survive. So 39%, or nearly 2 million. So that is a significant amount of our Pennsylvania population that is struggling to make ends meet, that are struggling to make ends meet. I am struggling with words today. I apologize. And are working every day to ensure that their household stays above and afloat from before going under. So something that we like to talk about is also the demographics of ALICE. And I have this great graph here that kind of shows you how these populations break down. And you can see that there is an inequitable divide between these populations. So Black populations are 3 out of 5 more likely to be ALICE or below that ALICE threshold. Younger people as well are more likely to be ALICE. Single parents more likely to be ALICE. They are struggling to survive, to make ends meet, and to provide for their household. So this is just another way to look at this population and truly understand what is happening on the policy level, but also in the actual community level of who we need to target and assist and provide for in our communities. So I mentioned that survival budget, and these are the numbers to kind of stack up what it looks like. So in the gray line here on the left, you have federal poverty level, and that is for a typical job in Pennsylvania. The typical job is the retail salesperson, and you're making about $11 an hour, and you're making above that federal poverty level. So what does that mean policy-wise? That means that you're not typically eligible for a lot of the assistance programs and government assistance programs out there to ensure that you are financially able to survive. So that's one thing to take a note. Another thing to look at is our survival budget compared to the federal poverty level. We are measuring much higher than what the federal poverty level is indicating what poverty is supposed to be. So these are the numbers that are, again, the bare basic minimum amount that you need to make in order to survive in Pennsylvania. And you can see down below what that income looks like from a monthly total to an annual total based on the household makeup. Again, I like to mention that these numbers are conservative and they are not the goal. So when we take a little bit stronger look at what financial stability is in Pennsylvania, you move towards the household stability budget. And you can see these numbers are a little bit higher. So for a single adult, you're making an annual total of $44,000 a year. And with that, you're getting about a 10% savings. You're getting a little bit better housing. You're getting better food, transportation, more reliable transportation, things like that. And you can see $44,000 for a single adult is a significant chunk of money to be making to be financially stable. Many single adults aren't making that to be considered financially stable, which is interesting to look at how our economic structure is in Pennsylvania. Same for a family of 4 with 2 in childcare. You're looking at about $118,000 a year to account for and to ensure that your family of 4 can survive or can be financially stable. So I also like to take a look at the economic breakdown of Pennsylvania, especially to kind of show how we got to this point for ALICE. So on the graph on the left, you can see that low-wage jobs have increased significantly over the last decade. That is a 75% increase right there for low-wage jobs. And these are the jobs that are not paying people to be financially stable. And then on the right for this pyramid graph, you're seeing what our economic breakdown is and the types of jobs that are available. So we like to break our jobs down between innovators and maintainers. Maintainers are the jobs that are our infrastructure, our nurturers. So they're building up our infrastructure and they're caring for our people. So you're talking about healthcare workers, you're talking about childcare workers, teachers, you're talking about plumbers, construction workers, things like that, that maintain our economy, maintain our infrastructure, and ensure that our state can continue forward and be successful. So these truly are this population truly is the backbone of our economy. And one thing that I also like to mention is, you know, last year, COVID-19 really wiped out a lot of those jobs, especially. And so if we're talking about what these impacts are with COVID-19 in relation to this population, it is quite detrimental. So we need to make sure that when these people return back to these positions and continue to return back to these positions, not only are they available, but they also pay a family sustaining wage for them. So that's kind of the background on ALICE. And now I'm going to kind of switch this presentation more into the health inequities that come with this population. So you can see here in this graph what the uninsured population is in Pennsylvania, and especially in Lancaster County. Lancaster County has a large uninsured population for people that are living below, that are under 65. And so what does that mean with this whole ALICE population? Well, I mentioned the jobs in that previous slide of what kind of jobs they're filling into. They're filling in childcare workers, food services, construction workers, things like that. A lot of those jobs don't have sustainable healthcare access. And so that can be very detrimental to this population because that is an additional household cost that is now being added onto their monthly expenses to pay for things that may not, that may not be feasible. So one thing with ALICE is that they are always one emergency away from falling into poverty. So again, with the COVID-19 pandemic, that was an emergency that turned into a year. You're now having this long-standing emergency and these people falling back into poverty because they don't have access to things like healthcare and being insured. Sorry. This is another graph too that shows households below the ALICE threshold for children who are uninsured. Again, Lancaster County has a very high uninsured rate for children that are living below, that are ALICE but are also uninsured. Health insurance status has a significant impact on when and where people can access healthcare and how much healthcare costs and overall health status. Health insurance is particularly important to children who need regular care for healthy growth, including, you know, checkups, quality vision, dental care, preventative attention for illnesses, things like that. And having a lack of that access to healthcare can truly set these children up for a rough path forward in their life if they don't have these already necessary healthcare coverage at a young age. The last graph I wanted to show here is percentage of households below the ALICE threshold and the provider rate available for mental health. Mental health is essential, and over this last year, we have seen how trying things can be for people. And so a lack of mental health access to providers and things like that can decrease the quality of life, especially for this ALICE population who has already had a substantial decrease in quality of life for simply being unable to be financially stable. So you can see in this graph, especially that there are significant amounts of mental health provider deserts across Pennsylvania. So a lack of access means that people are not getting and seeking the help that they need, which could lead to increased rates of morbidity and mortality. It could also lead to increased rates of self-treatment that may not be healthy or could lead to even more disaster for their household and for their families. So this is just another thing to look at when we talk about ALICE as a whole, is what are the different types of factors and indicators that go into this population and the overall quality of life and experience that the ALICE population has in Pennsylvania. So I mentioned a little bit here about COVID-19 and ALICE. COVID-19, again, has truly impacted this population. They were the most vulnerable before the pandemic, and now they are even greatly more vulnerable because of the lack of access and the lack of assistance programs for this population. So I'm going to show you this new data that we have. We're actually going to be launching this analysis tomorrow morning. It's our COVID-19 Impact survey. We did a first survey back in August of last year, which was a 6-month review of what the pandemic has done. And then we did a second survey this March that marks the 1 year out. So in that data, one thing that was very noticeable between the two surveys is an intense increase in mental health concerns, concern for people's mental health, concern for accessibility to mental health providers, and a concern overall for healthcare issues beyond just COVID-19. So in this graph, you can see both the ALICE population and the non-ALICE population have an increased concern for contracting COVID-19. Next to that is then mental health and well-being, and following that is other medical issues from COVID-19. So healthcare is on the mind of this population. And I think we have a really smart and opportunity to talk about these types of issues that are on the minds of Pennsylvanians and on the minds of everyone across the nation, to talk about this accessibility issue, to talk about people not being able to get these services that want these services. So this is just another kind of graph to show that this conversation isn't out of nowhere. People are thinking about this, people are talking about this, and I'm really excited to hear the rest of this panel talk about that and understand from their perspectives as professionals in the healthcare industry, and give their insights on what they're seeing and what they are working for. The last thing to mention here is accessing the data. All of this data is publicly accessible, and I encourage everyone to look at it. One thing that is helpful about this ALICE data is that it backs up a lot of the advocacy lifts that most people are doing. So one of the areas that you can find our ALICE data is on uwp.org/ALICE. That is our landing page. You're getting the full ALICE report and our full COVID-19 impact survey. The one from 6 months ago and the one that we're launching tomorrow will be up. And you're also getting our advocacy and our calls to actions, things like that. The other area to check out this data is through unitedforalice.org/Pennsylvania. And that is more data heavy, those graphics, those provider rates, the uninsurance, all of that is on that website. And again, I encourage all advocates and people interested in this to take a look at this website and to really grasp this data, because it truly tells an interesting story that is often overlooked, I believe, in a lot of policies. And lastly, this is my contact information. I'm always accessible. I love talking about this data. I want to talk to you all about this data and connect you with all these resources. So if you ever have any questions, feel free to reach out to me. Thank you, everyone.
This is where we would normally all applaud, and Rebecca would hear our appreciation. Of course, it's still Zoom room, but thank you so much, Rebecca. So one of the things that I think we've learned, hopefully over time, is that the challenge with data is, number one, it doesn't tell context in many cases. And number two, we only learn what we know to ask. And a lot of that is driven by funding, by systems, by those things. And so what it ends up meaning is that a lot of particular perspectives or communities get left out of that conversation. So, all I'm saying here is that what we're now going is from data into both sort of data-driven work that many of these folks do, but also anecdote, also context. And so I'm hoping that what we'll hear over the next period of time is helps us to learn and understand the topic of this presentation is, are you being served, right? You have that sense, oh, the doctor's ready to see you, right? Are you being seen, right? The doctor's ready to see you. That's one way, but is the doctor seeing you? Is that person actually understanding what you as a unique person bring? So here we've got a panel that will be able to help us understand some of their own experiences, but also the communities that they work with and represent, and ways in which maybe they aren't always seen, even when they're being seen or treated. So without further ado, I'm going to invite Susan to help us navigate this conversation as she's been doing through this entire series. Thank you, Susan. Thank you, Rebecca. Thank you, panelists.
Well, I'm interested in hearing from people, on the ground. Where are we? Where are we in this access, both by people that would fall into the ALICE designation and many other designations that we are starting to learn, and certainly learned a lot during COVID, are not having equal access to healthcare. So I'd like to start with Dr. Livingston. And what are you seeing as far, are we there yet? Or how far do we have to go to recognize people equally when it comes to healthcare?
Yes, thanks for having me on this panel. And unfortunately, the answer is we are not there yet. We have a long way to go. There's a lot more room for education on everyone's side, but specifically with the healthcare providers. What we're seeing from the OBGYN side is there is a significant increase in depression, as the ALICE data indicates. And so we just have a lot more work to do.
Sandra, are you with us right now? I know you.
I am. No, I am.
So how do you feel about this? You see a large Hispanic population. Do you feel like our healthcare systems are looking at everybody with equality? Do you think they're getting access?
I agree, as the other individual mentioned, we still have a long way to come. I know that the healthcare system is moving in the right direction. They're trying to move that needle to ensure that they're providing equal access to not only the Latinx community, but all of the Black and Brown community as well. And I just believe, in regards to mental health and other services that are provided, we all need to really look at it through a different lens and ensure that we are providing equal opportunity when it comes to the healthcare, and ensuring that language barriers are looked at to ensure that the patients can reflect themselves among the providers, staff, and even from the front desk.
Well, that is important. The language barrier. Dr. Hamblin, were you going to jump in there? So I wanted to ask Karen next. So what we saw a lot of during COVID is disparity in both access and care quality among people of color. And so from your perspective, was that something that affected the population of LGBT people during COVID? And did it just bring to light disparities that were already there? Or did you start to see some other things that concerned you?
I would say, the 2020 LGBT Health Needs Assessment stated that there was 61% of people reported discrimination in healthcare, and that was up from 56% in a report that was published a few years ago. So
that sounds like we're going backward.
Sure is.
That's not good.
Nope, sure is not.
No, like, can you give us examples maybe, or an example of how that, affected someone?
Well, so every issue is an LGBT issue. We happen to oftentimes be forgotten, right? Even within this really well thought out presentation, we haven't, like, there wasn't any mention of the LGBT population, right? And our intersections are actually the most vulnerable on the planet, right? So you're looking at somebody, say a Black trans woman, right, who is definitely one of the folks that's not going to be easy for her to go into an ER, right, or into a doctor's office and feel like she's going to be treated with dignity.
Okay, and so what are some of the things that you expect to change? What are some of the specifics that you could say, we need to change this so that all people are accepted with dignity?
So funny you mentioned that, Susan, but Dr. Livingston and Dr. Hanlon and I, with Patients Are Waiting, we are starting Lancaster's first LGBT health consortium to connect providers. I think a lot of times the issue tends to be that we work in a sort of insular environment, and so I have many years have been sending my clients, I'm a therapist, so I send many of my clients to Dr. Livingston for no questions asked hysterectomies, which is a huge issue for our community, and have gotten nothing but glowing results. And on top of that, she reached out to me after the last health panel and was like, hey, I use this term pregnant mothers over and over. I can't believe I did that. I need your help. Let's talk about this, right? And so this is where the real work is, I think, in terms of us as leaders of healthcare and doctors, things like that, being able to connect and to support one another, right? And know that Elisa Jones says, culturally humble care, right? We can't come in saying, we're affirming, we deserve more than that. We need to know that we continually come up and, our doctors will be humble to know that we're always learning, right? So that I think oftentimes, aside from the fact that we live in, kind of a, conservative area religiously, that there are a significant amount of doctors that are affirming and could just use extra support. And then with the consortium, we plan to give scholarships to residents to incentivize, because any kind of research or training, because it's still an elective in most people's training. So I think that, at this point we can do more, and we certainly need more research.
Excellent, because I think maybe a lot of providers start at this point where they don't have a lot of knowledge about all people. So they're just going their regular way and accepting people or treating people in a way they've always been treated. Let me clarify. They have been treating people the way they've always treated people, and not necessarily with the kind of dignity and understanding that all different populations need. And we have statistics to prove that. But Beth, I'd like you to jump in here and just give us a little insight on how those kind of disparities might affect our community as a whole, as we strive to be a healthier community.
So much that I want to say, but I'll start at a high level. And the pandemic really starkly illustrated that for an economy to be healthy, people need to be healthy, right? And large corporations are already recognizing that it's not sufficient for them to just have healthy employees. They need healthy customers. They need healthy distributors. They need healthy suppliers. And so, and they're starting to react to that. They're now, some are explicitly hiring public health expertise into their own ranks. But beyond that, there's a huge opportunity for the business sector and the public health sector to start to collaborate and work together more proactively. Because fundamentally, we now it's now been demonstrated what many of us have known for a long time. Investment in public health is economic development. They're inextricably combined.
And so how do we make that investment so that, how are some of the ways we can make that investment so our economy thrives and people can depend on a system that accepts them and provides them with healthcare equally?
Well, there are a lot of strategies, and our other panelists have talked about what they're working on locally, but just taking a step back and looking from a higher level. One of the most significant underlying factors is social stigma, right? Social stigma has profound and not very well understood impacts on health risks. And when I say social stigma, I'm talking about racism, I'm talking about homophobia, I'm talking about transphobia, I'm talking about sexism. And until we address the root causes of that stigma, we're going to have challenges improving access, improving the social determinants of health that are impacting the ALICE population and across minorities. So I think that, and the past years have done a lot to demonstrate this. To me, it illustrates the importance of continued advocacy and activism, because the more we can elevate the visibility of the existing disparities, the more likely we'll have decision makers come to understand the financial and social value of addressing those disparities.
And it sounds like we're not making progress, Dr. Hamlin. Is there any responsibility on the patient to demand good health care, to expect it, to speak out about it? Or do you think that the healthcare providers are going to be educated on these issues from within healthcare systems?
That's a really good question. And I think, so I'll start with the direct and short answer is, it's not on a patient to come in screaming, saying, treat me properly, treat me like you would treat any decent human being, treat me how you want to be treated. That's implicit in arriving anywhere for care. It is absolute that a patient, a person existing, wants to be treated well, whether that's in healthcare or outside of healthcare. When we're talking about public health, I think one of the things that through the protests of the last year and the social climate really opening conversations, what remains at the forefront of my mind in first steps, next steps, is always to open conversations and to broaden your view. If we're constantly learning, if we're exposing ourselves more, and if we're growing, because the more experiences that we have, the more broad and inclusive our perspectives can be and our approaches to problem solving. I was just in the chat, Beth, you dropped some real gems. I mean, I wish I had like in my mind, I'm a DJ. So when you were saying things that I put in the chat here, that the pandemic illustrated that for an economy to be healthy, people need to be healthy. It sounds so simple. But, when we were back in April and May of last year and businesses were closed, what became essential? It was very interesting. For some people, what was essential, I have to get to Costco or to my, whatever the, grocery store that you use, and needing to be there. And at that moment, the grocery clerk at $11 per hour was absolutely important to everyone. And everyone would say, thank you so much. And, I think that probably fights in a grocery line were few and far between. At the same time, when the vaccination rolled out, it was essential healthcare workers who were prioritized. And what does that say to someone? You are deemed essential to come and work. You are not deemed essential to be protected. So, I think we all do have far ways to go. But when I think about healthcare and what we can do, some of it is having these conversations, continuing to grow. It's not enough to be in our fields and our specialties and not have conversations. And healthcare, we have continuing medical education. It's lifelong learning. And when I say healthcare, I mean that I say that to mean health and anything to do with your health. This is also social services. If we are caring for people, but we think we've got it down pat, there's nothing else that I need to know. I passed my, insert said, exam, then we're really missing the mark, and it may be time to do something else.
Well, how much are the health systems that you work for, or how much are the health systems that you're dealing with putting pressure on providers to give this kind of equality in service? Or is it more up to the doctors themselves to educate themselves? What are you finding? Could be Dr. Livingston or.
So I'll just jump because I was already,
Sure.
I'm on a roll.
Yeah, go ahead, Dr. Hammond.
I think there's often what makes it to, out front, whether it's a certain certification or an accolade, but then what is the feeling on ground? And so I know for myself, there is much more that I can learn, and I do find that through different patient experiences, those are things that grow me as a provider. And so, I bring myself to medicine, and there are certain patients who seem to open up with me, and whether that is for having a perceived shared background, or whether it's just like, I don't know what I'm doing, but people talk to me. And so I appreciate that. And what that does, it can open the door for learning and growth. But there is having a designation and having some learning from a system level is important, but there's also the individual work as well.
Susan, I'd like to comment. Dr. Hamblin put it so eloquently, but I'm probably going to speak a little bit more brass than she did, because the reality is there's so much work to be done. I mean, I recently made comments that did not meet the entire worldview. And again, I'm considered a preferred provider in specifically the LGBTQ community. And so someone with so there's a lot of work to be done, and I think we have to push ourselves to a higher standard. I'm an OBGYN physician who is the department chair at a Lancaster hospital, and it actually pisses me off at how much work there is to be done. And the reality is there are folks like me and worse when I talk about the education deficit. As an OBGYN doctor, our training includes 4 years of medical school, and then we go and we do an OBGYN residency, and we pat ourselves on the back because we're told we know everything about women's health care. And then we go out and we're put it into the world to say, hey, go practice on women. And part of that issue is not everybody sees themselves as a woman, and we don't get that training.
I was going to ask you that. How much experience and training have you had on those issues?
So without dating myself, because I graduated from Penn State Hershey residency in 2006, so I can speak from that perspective. But back then, there was very little that we learned. And essentially what a provider has to do then is take annual training that's required through the hospital, or reach out to the Karen Foleys of the world and say, hey, I'm stupid, please help me. I have a lot of work that needs to be done. Just by the way, I love Karen. And it's important. Exactly. And the level of work that we have to do is just insurmountable, and it's embarrassing. And I think that part of the solution is recognizing that. And when you have a deficiency, A, you recognize it, B, you do everything in your power to fix that, not for yourself, but for the community that you're serving.
Well, that's good to hear, but I don't like to hear it's insurmountable, because somehow we're going to have to catch up with other countries that have figured this all out. Now, Sandra, I have an interesting question for you.
Absolutely.
The Hispanic community relies on SACA and a lot of their facilities a lot. Do you think that is an outgrowth of treatment by mainstream medical providers, or is it something else?
I think it's a combination of that, as well as the trust and the rapport that SACA has built in the community. In the Latinx community, just like any other community, we tend to go to where we feel comfortable and that we can see ourselves reflected among the people who are helping us. We do reach out for health care services and provider based on word of mouth. Many individuals in the Latinx who are trying to fit in the culture of medical, and providers, it's very difficult for individuals to come in who are just either migrating into the area, who have lived in this area. I lived in Lancaster City for over 35 years. And I can say that even my own provider, I cannot see myself or reflect myself within my own provider, and I have to seek elsewhere just to be able to say, wow, I really can relate to this physician. And don't get me wrong, my physician, I love my physician. He's been my doctor for quite some time. And he does, as Dr. Livingston said, try to get himself educated, try himself to include in his whole practice that is being more inclusive for everyone, all their patients that they're being served. So in SACA, we provide a lot of services, and particularly, I know we've been discussing the mental health, the behavioral health. We strive to ensure that all of our staff and personnel are truly bilingual, from the person who comes into the front door and checks you in as the scheduler, to the individual who's taking your vitals, to the physician, and ensure that the person is leaving with a great understanding of what that provider is sharing with them, and that they can better their health based on the education and the language and the conversation that is occurring. That's ultimately really important for the Latinx community, that when they're going into that exam room, that doctors, taking their time to really sit there and listen to what they're saying, and not just checking a box, okay, we went through this, we went through this, we went through that, but more saying, okay, how can I help you? What are your medical needs? What are you going through right now? Let's go through this history and see how I can best help you and connect you to the other providers in the area that can really serve you to the best. And I think that's something that SACA does very well in understanding and broadening their partnerships and collaboration with so many different stakeholders in the community, with healthcare providers, to ensure that if we cannot provide a service that we have been assessed in our community and know that there's a need, that we know where to send these individuals. And because we are being trusted upon, that our clients are actually trusting us to say, okay, if Sandra sends me to this organization or to this provider, it's because she knows that they're going to set me for who I am, regardless of where I fall into that spectrum of service. So I think that is very important across the board to be able to provide that information and build that rapport with everyone, not just the Latinx community.
I agree, but it's a good example. So why don't we just all have our own little healthcare providing systems? Why is that not a good idea? Why don't we have one for Black people? Why don't we have one for LGBT people? Why don't we have one for the working poor? Why is that not a good idea?
Well, I think that's more of a reinventing the wheel versus working collaboratively to be able to help the individual seeking those particular services. And don't get me wrong, not everyone is specifically have the education background or is able to navigate everything when it comes to healthcare. There's people that specialize on particular services, and that's who we should direct our clients and our patients so that they can also be comfortable going to those particular locations. So we don't necessarily have to have different healthcare providers that addresses the Black, brown, the white individuals, but more inclusive and diversity, just diversifying our services to ensure that people feel comfortable to go to these locations. Secondly, there's so many individuals in our community that reside in Lancaster City and County who not one provider can actually service everyone in that area. So we've worked together, and if we can open more opportunities for people to actually go to the location where, maybe the capacity of the facility, maybe the capacity of employees right now, personnel, there's such a lack of personnel in all aspects of the workforce arena that it's very difficult for individuals to be able to open, over the weekend, in the evening hours. Those are other things that we need to really take in consideration as we're providing services. Can this particular provider extend their hours? If they're not, where can we emphasize or help this particular provider or other providers to be able to work together in unity to be able to help our community?
Karen, do you feel like Lancaster County is particularly behind in this effort? And why do you think that is, if they are?
I'm not sure if I could entirely speak to that because I'm coming from Chicago. I moved here about, 10 years ago from Chicago, and there wasn't an LGBT center. So, I was like, that's odd. So we started one. But I would say, we're probably behind. I would say that there's really no way to measure that yet, though. I think that there's the human relations, the HRC index, and then human rights campaign. That's what it is. I always get that confused. But they have this HRC index, but it's really, I wouldn't say that would be something I would rely on to guide me to find a practitioner. However, I do know that, like I said, there are several very, very advanced practitioners here, willing to do the work, wanting to connect, and very interested in doing the research. I think that, like I said, people still aren't even asking the SOGI questions oftentimes because they feel uncomfortable. And if you're talking about advocating for yourself, really, I feel like Dr. Hamblin said, I don't think that that's fair to ask for our community, that, it's hard enough for, say, a trans woman to make a phone call or to walk out of her house, let alone, advocate for something that happened recently. Someone called a local clinic and said, hey, I'm calling for gender related care because they had a referral from me. And they're like, no, we don't do that here. So, but this person had the wherewithal to be able to say, no, I actually know that this is, this is what this doctor told me, and this is what blah, blah, blah. But this person was nearing 40, a top level executive, right? So that's not typical of our community, right? It's hard. People won't even make a phone call. Oh, they'll just hang up, right? And then that's it. You've lost that patient. So, and that's at a place that does actually have, several very, affirming providers, so I think that what we're doing in response to that is training, Union Community Care is doing a great job of hiring us to do training of their front end staff all the way through doctors, anything like that. But the reality is, so anyone doing sort of gender confirmation surgery, things like that, it's still an apprenticeship situation, so there's one doctor in Pennsylvania, Dr. Lease, who then trains Dr. McGinn, who then trains, so it's, again, Dr. Lemons had said, you really have to seek it out, and we have to create it. That's the thing. We have to create these opportunities. So.
And we've seen that progress go so slowly with even healthcare of women and not being taken seriously as men. And so I can only imagine that some of these smaller groups are probably just agonizing of the slow pace it takes to make some progress here.
And I just want to say,
go ahead.
And this is again, similar to what Dr. Livingston said, that we are stuck in a kind of binary way of thinking, like men and women, right? And then we forget, again, even right now, forgetting that we have to clarify. You're talking about cisgender women, which means, you align with what you were assigned at birth, right? But then, and oftentimes non-binary and trans individuals are forgotten in the equation, even all of the conversations. So
Well, let's not do that today. Let's not forget.
let's not do that.
Let's not do that. Yeah. So Beth, what would you recommend if you had a magic wand to somehow unite all these concerns in Lancaster County to ensure we're getting the best possible health for all people?
Do you have a magic wand, Susan?
Yeah, in my back pocket. I'm going to bring it out later, but
All right.
it's still something we can dream about. So,
Well,
I mean, you recently got your Master's of Public Health.
sure.
So population issues, I'm sure, was a big part of that.
It's, you know, it's really about finding a way to direct already existing resources more effectively. And so zooming out to a country level view, and I'm sure that my audience is well aware of this, United States, in terms of life expectancy at birth, United States ranks about 40, well below all other developed nations and a number of developing nations. On the other hand, the United States spends more as a percent of GDP on healthcare than any other country in the world. We're not getting the benefit from what we pay for. So I did a quick back of the envelope calculation. If we reduced spend on healthcare by just 1% of GDP, that would be $214 billion that we could direct to addressing the social determinants of health, to permanently improve the status of people, to ensure that they can live healthier lives. If we approached the level of spend that the average of high income countries in the world, it would be $1 trillion that we would have to deploy. So how we're spending money is a fundamental part of the problem, I think. And that's why I'm such a strong advocate for focusing on the determinants, almost all of which are almost inextricably linked with poverty, right? And so in kind of bringing it back to where the conversation was before, I think there are a couple of very large barriers to having providers that are sensitive, compassionate, and attuned to a variety of patients. And the first is, and I saw it in business when diversity inclusion first started to become important and received lip service as important. I was the VP of diversity for Armstrong for a few years. And so they talk the talk, but they didn't really walk the walk. And in some of the consulting work that I've done with large health systems, there's been a similar movement. They're starting to do training. They're starting to make it diversity inclusion as an important part of their mission. But if you look at the structure of their employees, look at their hiring practices, look at their promotion practices, things haven't really changed much. And until we employ the tenets of diversity and inclusion throughout an organization, we're going to have a hard time moving the needle, because it does require individuals to care enough to be open to changing, to be open to different experience, and to be aware and compassionate of others.
And how does public health play into that on a local level? How would you see that would improve or not improve our issues here in Lancaster?
Well,
we're the largest counties in the country without a public health department.
Right. And so the most obvious example is what's just happened with this last pandemic. If we'd had a public health department, we could have had tracking and follow up right out of the gate. And as we've discussed, it is the poor across genders and races that suffer the most, and were dying at higher rates, were being hospitalized at higher rates because they didn't have access to the opportunities, including having to show up to work at the grocery store for their $11 an hour job instead of sitting on a Zoom meeting. A public health department would have allowed us to react and reduce the spread much more quickly than we were able to do. It also would have facilitated a much more quick and broad vaccination program, right? Which we're still really struggling with. I heard just recently, I spent many years in Pittsburgh, and my friends there, their vaccination rate is over 70% already, and we're below 50%. That's a problem. And so one of the things that a public health department can do is shine the light on the dark corners where people are being ignored. And that's where a lot of the transmission and perpetuation of health risks happen.
Thank you. I think that's a good description. I think you put it very succinctly, but in practice, what are we still seeing? Dr. Hamblin, what are you still seeing as some of the most egregious situations, I guess I would say, when it comes to access to healthcare, good healthcare?
Well, I think that so I'm going to flip it. I think that we have a unique opportunity here in Lancaster County, and in Lancaster City. We're small, but we're not tiny. And there's lots of conversation and good energy. There's great collaboration. And so I think that we can do better than we have done. Beth's point about public health being, an economic issue. Basically, our business community is very smart and agile, and our people are very caring, but care and concern doesn't always translate to like action and innovation. It translates to more meetings and more discussions, doesn't necessarily translate to change in policy and whatnot. So I wonder if we were, you're hearing me, right? Okay, so, even if we just said, look, at this very moment, we do not have a public health department. But when we're looking at the basic level of achievement, attainment, stability for our people, for our Lancastrians, or Lancaster, however you say it, there's things that we can do right now with what we have, right? As our business community is coming back, all of the businesses, I think it's wonderful, United Way's program, Project SOS, that's like, okay, share our stimulus. But if we think about it, what went wrong in the first place that, you have people who really needed a stimulus, not even really a stimulus, just something to help sustain, that didn't get, and those that got it, that have it to give back. There's a mismatch. And so I think a shift from the individual focus, or what each individual can do, and also a pivot from, let's take, the holistic, view where we're going to figure out the problem in a comprehensive solution, which oftentimes results in no action at all, no movement, because we can't get an agreement. And we can act in our spheres of influence with systems thinking and systems approaches, because whether it's from business saying, you know what, I realize now that the wage we were paying is absolutely not livable, and I can't get my people back to work, and all of this. I've heard many, managers say these things. And part of it is that, when you're paying somebody $12 an hour and they're risking their life, and then they don't feel valued, I think that people of many different economic backgrounds have had it up to here. They're like, I'm not going to die for this job, and I'm not going to die for this manager. And so I think that in some ways, the pandemic has emboldened people to say, I'm worth more than what I am receiving, and I've had enough, and those things, and we can do better as a community to change the way that we are addressing things from systems levels. Let's take it out of the individual, because one-on-one we can do great, and then what does that mean for the next 5 people that, you know, that we interact with? But we can change things on systems levels, and when our systems are functioning, firing on all cylinders and working better, then we can, you know, have you know, Beth and Karen, Rebecca, you know, come up with solutions for, you know, the comprehensive work.
And what do we need, Dr. Livingston? What do we need to get those systems working again?
I think we need to put forth organizations like we did. So for example, like with our Diversifying Doula initiative, the whole purpose was one person can't do everything. And so if you create a comprehensive team and a comprehensive team approach when you're caring for people with specific needs, then you can round everybody up and get the level of expertise together that you need. I really like the idea. We're implementing it in our practice where we have a team approach to how we care for people. We have doctors and nurses and midwives and doulas and mental health specialists, therapists, social workers, so that we're getting the job done and not just being decorative or performative.
Yes, I know someone in that program, and I think it's going to be a real game changer as far as access to good quality care after birth, during birth, and before quality care. But Karen, is there any sort of service, a doula service for a person who is in LGBT, a trans person who is giving birth? Is there any sort of a doula care set up now for that?
So I was going to mention and give a shout out to Claire Reiner, who is a nurse that developed the kind of first local transmasculine birthing program, sort of tailored to two specific individuals, because, you know, and she called me, she's like, no one's done this yet. I was like, you got it. So she did. And I know Dr. Livingston and I have been talking about different programs, and, you know, I think that there are plenty of doulas that are queer. I'll just say that. But it seems to be kind of a large part of our population. A lot of lesbians, they like the doulas.
I did not know that. That's interesting. That's interesting. And I think that that's something that wouldn't have even been discussed 10 years ago. So maybe there's a tiny bit of progress being made here. I'm not sure.
I think I just want to kind of mention the one thing that I find from moving from Chicago is sort of the institutionalized mediocrity of Lancaster. You know, this, like Dr. Hamlin was saying, this, you know, there's not a real effort or impetus to like complete an action. So there can be a lot of like talking in meetings and things like that, but like, you know, coming here from Chicago, where it's like, you know, the very hard like work ethic, you have to have like a fine, like your like specialty has to be like, you know, on the tip of a pin, you know, like that kind of thing. But like here it's a little easier, you know what I mean? It is like, there's something about the, like Dr. Hamlin was saying, it is very possible to do things, right? Like us launching this health consortium, like I feel totally excited about it. And I know it's going to be very successful because no one's doing it. There's no competition. So, so I kind of feel like folks, I think more than anything, sort of like Dr. Hamlin was saying, we need to help folks understand that they can do these things, right? You can, you know, help create systemic change.
And so tell us more about the Health Consortium. You mentioned it earlier. Exactly how can people get involved in that or attend it?
So we are just sort of soft launching this. We'd planned on announcing it on Saturday, but then I was like, well, here we are. So on Saturday, we are doing, this is one of the things that we are working on with Patients Are Waiting and Union Community Care. We are hosting 2 vaccination clinics that are really like specifically about intersections in our community that are very hard to reach. So we are very lucky to have, you know, riding on the coattails of all of their hard work for Patients Are Waiting. And we have on Saturday at the Water Street location at Union Community Care. Basically, my neighbor, I didn't realize, happens to be a ballroom legend. And so she is, you know, a Philly ballroom legend. And I can explain what that means for other folks later, but basically, you know, a Black trans woman, an activist and a performer will come in with a DJ and bring in, you know, all of her friends and folks that wouldn't typically, I think, come to an event like this. I know, I'm so excited. And we'll, you know, like we'll have DJs all day, and we're gonna have really good food, and we're gonna have pride swag, and patients are waiting, have it all decked out already. So that's kind of where we're starting. I think that like I guess kind of feel like if you just create it, people will come, you know, like that typically is the thing. You may have to do it like 3 or 4 times, but people will eventually start coming, you know, so I kind of am applying that to this.
So what do you want the outcome to be?
Outcome of the consortium?
Consortium, yes.
Oh, well, the consortium, yeah, sorry, I got sidetracked because I got all excited. But so the consortium really is exactly what we're talking about, right? So there's, you know, hospitals make it real hard for doctors to talk to one another. It's like, you know, it's real stingy with their, like, you know, like there's not a whole lot of coordination of care because of the insular nature. And then like Dr. Livingston doesn't even know Dr. Lake, you know, like those kind of things, like didn't even know, you know, they're like, you know, a stone's throw away, and 2 very, very, you know, well-known doctors, right? So there's that. There is the ability to connect our providers to support one another. We will have to teach each other. Like I said, this will end up being like an apprenticeship situation where we're gonna do a little show and tell of our skill sets because no one's doing it in residency programs. And I'm talking about all providers, not just doctors, right? We're talking about mental health providers, anyone in any kind of healthcare position, right? And folks that are, you know, like Beth, you know, people that are leading public health and should be talking to, you know, we will be talking to doctors and, you know, educators about including this in their curriculum, you know, and sort of changing that. And again, we'll be offering scholarships to residents to sort of incentivize research opportunities and training.
That's great.
And again, yeah, so that's the basic gist, connecting, identifying, and then supporting so that we can eventually, and I don't think it's going to be very far off, but I do think that we will be able to know that there are specific clinics, specific offices people can go where every single intersection of our community will feel safe and seen and celebrated, and they won't have to educate their doctors.
Great. I think we need to give a shout out to Union Community and Elisa Jones for leading a lot of those efforts. Patients are waiting. I think this would be a good time just to acknowledge that there are systems and professionals that are working on these issues. Sandra, do you feel that there's something that we might not be addressing in the Latinx community about healthcare? Is there anything that you have as a pet peeve that you wished that would come to more of a public light?
Good question. I think the transparency in regards to, and not necessarily the Latinx community, but understanding the uninsured population and the underinsured population that we serve that have, you know, very little access to, you know, healthcare or health coverage that is affordable, is being more transparent. We see that the healthcare providers, as well as the health system, aren't very clear as regards to the cost of the services that the community or the patients are receiving, being more transparent in that perspective. But I also think that for the Latinx community, interesting, I was in an appointment interpreting specifically from my mother before I jumped into this call. And I asked whether or not there was anyone who was in the actual procedure room spoke Spanish, or whether or not my mother was going to have some type of interpretation in the room. My mother is somewhat bilingual. She understands, but when it comes to medical terminology, you know, she doesn't really understand everything that comes aboard. And it's interesting because the lady at the front desk said, well, they have a tablet that they're going to use if she does not understand something. And I said, oh, really? I said, well, can I go back there and do the interpretation for my mom? I mean, technically a certified medical interpreter, am I able to do that? And they said, no, you are not able to do that. We will use this tablet. So sure enough, they did use this tablet for my mom, and the person on the who's doing the interpretation actually is not Puerto Rican. The dialect between a Puerto Rican and a Mexican, a Colombian, or any other Latin communities, when they interpret medical terminology, are not the same. So there was a lot of words that my mom did not capture in that particular visit because, or understood, because the person who was actually doing that interpretation did not speak our language. So I think in the healthcare arena, this is definitely something that is needed. And I know we continue. I understand the fact of not having a child, a minor doing interpretation in the room, or, you know, and it tends to occur, especially for individuals in this community who do not speak the English language. But if you aren't able to truly provide someone who can be at the same level of the Latinx community or any other races, ethnicities, when it comes to medical care, then we shouldn't necessarily put someone on that tablet to interpret a medical terminology that can affect the health of the person who's receiving that service. So I think it's also being more aware that these language lines that we're utilizing, or the healthcare is utilizing, is not necessarily good for or utilize. I mean, they're trying their best to utilize it best that they can, but it's not really doing the job for those who are the patients who are receiving the service and who are really going home still unknowing truly 100% what that medical provider has shared with them, or what is their discharge plan or things like that, or how to follow through with that.
I want to piggyback on that. I think that what you just described is, you know, just a real testament again to the importance of diversity in medicine. You know, our healthcare community and the care community has to reflect the communities that we are serving. If we don't, then that needs to be prioritized. So part of, you know, the mission with Patients Are Waiting is to eliminate health disparities by increasing diversity in medicine. Obviously, you know, having the proportions of providers, you know, match the population is not the end all be all. It will not solve all problems, but our approach, you know, is really operate within your sphere of influence. What can you do? What's in your wheelhouse? And so, you know, for myself and the other board members, you know, our affinity is so much to students. And if you look at I was listening to a congressional hearing that was talking about physician shortage and primary care shortage that's projected in the next, you know, 30 years. And it was heartbreaking because at the same time, while I've been on this panel, I have a student who just sent me a message who's going to be reapplying to medical school because she didn't get in this year. And, you know, another student who got off of a wait list just last year, just before she submitted, you know, for her application. You know, we'll talk about, well, if we want to have executives or we want to have, you know, diversity in STEM, diversity in this, we have to start in the K through 12. Yeah, sure. But what about the people who are languishing in the pipeline? What about the increasing, like all of our students who are doing English as a second language in the high school? We can be steering those students to get medical interpreter certified so that they now have somewhere between $17 to $24 an hour as a job instead of working at Dutch Wonderland or one of these other places that many students work at. We can be innovative and it helps everybody. It then becomes an end economic. If we have, you know, appropriate and we're actually looking for the talent. Like we don't have a problem recruiting and finding diversity for janitorial services. We don't have a problem having diversity in food services. And you can order in whatever language you want, right? But why do we have such a problem for skilled things that are going to create economic opportunities? If we want it, we can find it. And so I think that that's some of the opportunity that we have here, right here in Lancaster, that's home to so many people from so many places. The talent is here. Yes, we can bring talent in from other places as well, but let's invest in the talent that is right here and see the value in the people. We don't have to jump over our Puerto Rican and Dominican brothers to find people from, in other places, we do have talent and local resources. Let's tap into those things while we also build pipelines and create additional coalitions, et cetera. You're on mute, Susan.
Usually people like it when I'm on mute, but what I was going to say is that I think what you summarized, Dr. Hamblin, is that communication is kind of the key here to moving forward. We need to talk among ourselves, and we need to talk to the broader community about these issues and other issues. I'm interested along the lines of what you said about medical school. How many fellow doctors when you were in training were also people of color? Probably few, Dr. Hamblin?
So the numbers haven't changed so much. My medical school class was 170, 10% of my class was African-American. Northwestern did a great job where there was a desire, there was there was a value placed on having diversity in the class by race and ethnicity, by languages, by age, and by so many different things. It's what makes up your class. And the only job of medical schools is to create the physician workforce for the country. And the job of residency programs is to train that physician workforce. So when we're looking at, the education system, and we can kind of keep kicking the can down the road, but I think, again, we can work from where we are. A question that was put in the chat or a comment was, that we're here, 30 people having this wonderful conversation, and we all care. It's 2:30, 3 o'clock in the afternoon, and we're here doing this. And so it says there's some things that can be gleaned from who's on the call. But I do think, yes, there is a bit of preaching to the choir, but we each have our own spheres of influence. And so whether you're coming from the Chamber of Commerce, or you're coming from, medical education, or you're coming from social work, there are things that you can do to advance equity, to advance and improve public health, whether it is reevaluating what is the lowest wage someone can get by working here. Do we give benefits, health benefits, or not? What is the actual, what is the actual delivery that, delivery on a promise of a better, stable, decent, life that we are doing, for our own teams, essentially. We can start there.
Thank you. Kevin, do you want to jump in here?
Well, I'm just, the annoying parent who has to come in and tell the kids it's time to go home. No one wants to see me pop back on. But hey, this has been a fantastic conversation. I've learned a lot. I've been challenged a lot. I've had things that were right. My own biases confirmed, right? We are all as guilty as those who frustrate us in our own silos. And I think that's part of our challenge. Those of us who do care about this, we all have people in our networks who do not have the same passion that we have about equity. We know, even those of us who are passionate about this, that we get the terms wrong, we say the things wrong, we offend someone, we make someone upset, and it makes us uncomfortable when we have to accept that criticism. And for those who aren't even trying to figure out a way of improving their language and those things, you get more resistance. But I always try to remind myself that part of my role is to remember that I didn't start where I am today. And so there's a value, I think earlier was mentioned the word humble, but there's I like to think of it as, how do we go forth by being firm but gentle, by positioning the ways in which we interact in ways that hopefully allow those who are harder or resistant to be willing to reconsider. Those of us, wherever we are, many of us have different ranges of where we are within privilege. I have a lot of privilege, and I have a lot of privileged access to other groups and other people, and it's my responsibility, whether it's fair or unfair isn't part of the point. It's my responsibility as someone who has privilege and access to areas and conversations to try to help advocate for, make the way bigger or better, the road wider for those who don't have that same level of access, who are being shut out, who are being ignored. I wanted to say a couple of really quick things that came out of this for me. One, Dr. Hammond was just talking about how do we retain the talent that exists here. My brother's an ER doctor in Pittsburgh, UPMC. He went down to Duke University, then he went to Hershey Medical for his MD, and he has his Master's of Public Health from Johns Hopkins. Not necessarily the easiest academic guy to follow as second brother, but I'm super proud of his accomplishments. But what's interesting is he's in Pittsburgh. Noel wanted to be a doctor from the time he was 6 years old. His entire life in Lancaster, from being a child, he was working to be a doctor. He was, valedictorian of his class or whatever. He got full rides to all these colleges. How was it that we had not found, he even volunteered at a local physician's clinic. How is it that no one laid their hands on him and said, I hope you're going to come back, that you're going to serve here? He was screaming in all ways, but with his words, to say, I'm going to be a medical professional and a good one. And our community was not set up to say, good. And when you go, come back. And so it's such an important point that we have a county of, when the census drops, it's probably gonna be 580,000 people in this county, right? Over 100,000 of them are under 18. What are we doing today to make sure that those, not just the best and the brightest and the doctors and the high professionals, but that those individuals see their future in the place in which they were born and or raised, is a really important thing about how we develop our community economically and those things. I also want to say another thing that's really important that I heard is the ways in which we sort of develop the inclusion, diversity, the equity, and the justice of our community. Right? I've noticed the rush that we have had as we've had a more awakening in our society of where we are not yet, to provide anti-racism training largely for white people and white institutions. If we got here because we overinvested in white communities and underinvested in non-white communities, then what is it that we're doing to invest in non-white communities and individuals and putting our resources in a place that helps those individuals be able and better able to support their families, to be in positions of leadership and those things? That's not saying we shouldn't do anti-racism training, but we cannot continue to overinvest in communities that have access, expecting a different outcome. Similarly, we hear Sandra talking about English and Spanish and interpretation. We have got to not only say, hello, those of you who do not speak English, here's some English as a second language training. We should also be training our staff and our leadership to learn languages, to learn Spanish, so that we meet in the middle, not just having one group having to come all the way. It's similar to, it's not just about accepting or being okay with someone being gay or queer or transgender. It's not even just about being affirming that they can do that. It's about being transformed ourselves. In ourselves, in our policies. It has to always be more than just expecting the other to assimilate to our ways, our power, our access, and saying, you're allowed in if you become more like me. We as human beings have to all become more like one another. And that's what I heard in multiple ways in today's conversation. I'm deeply appreciative of it, from talking about what business should be doing and thinks about doing, to what people on the ground are doing, to making sure that we don't expect people have to constantly advocate and demand for themselves, but that we ourselves also demand for our neighbors, for our friends, for our strangers, and yes, maybe even our enemies. When we think about our priorities as a nation and as a community, you find the priorities in the budgets. It was mentioned that we are one of the most highly funded medical communities, but not having the highest result of that. We have got to stop accepting good enough as being good enough. We spend more money for our military than the next 8 countries combined. We spend more money for our police force than anyone but our own military and China's. We spend more money on our medical care than anyone else, and we're not getting the results that we're supposed to be getting from that kind of investment. It's time that we begin to refund the community in ways that says what we were told we were being sold was was not what we were sold. We demand a refund, and we demand that we refund the institutions of care. Thank you everyone for participating. Thank you everyone for being here.
Thank you.
For your time and for your space. I'm grateful for you as a member of this community. Have a great day, evening. Weekend.
Thank you. Thank you, everyone.